Welcome to this deep and science-based exploration of obesity, a condition that is as misunderstood as it is widespread. Around the world, rates of obesity have reached unprecedented levels. According to the World Health Organization, obesity has nearly tripled since 1975. Today, over 1 billion people worldwide are classified as obese, including more than 650 million adults, 340 million adolescents, and 39 million children. These aren't just numbers. They represent real people, living real lives, often in pain, frequently misunderstood, and too often judged unfairly. Obesity is one of the defining health challenges of our era. It affects people of all ages, across all continents, and from every socioeconomic background. In some regions, it coexists paradoxically with malnutrition and food insecurity. In others, it reflects the overabundance of highly processed food, sedentary lifestyles, and deeply embedded cultural patterns. It is no longer a concern of only high-income countries. In fact, many low- and middle-income countries are experiencing a sharp rise in obesity, particularly in urban areas. But what is obesity, really? Beyond the surface-level images we see in the media, obesity is a complex, multifactorial disease. It's not just a matter of eating too much or moving too little. It involves a delicate balance of biology, behavior, environment, and social structure. It's influenced by our genes, shaped by our experiences, and exacerbated by the world we live in. A world that increasingly promotes calorie-dense, nutrient-poor diets, long hours of screen time, chronic stress, and insufficient sleep. Scientifically, obesity is typically defined using a metric called body mass index, or BMI, which calculates weight in relation to height. A BMI of 30 or more is considered obese, while a BMI between 25 and 29.9 is considered overweight. Though BMI is useful at the population level, it's a blunt tool when used to assess individual health. It doesn't distinguish between muscle and fat mass, nor does it account for where fat is distributed in the body, a crucial factor in assessing metabolic risk. For example, visceral fat, which accumulates around internal organs, is more harmful than subcutaneous fat stored under the skin. Some individuals with high BMIs are metabolically healthy, while others with normal BMIs may still have serious health risks due to hidden fat deposits or insulin resistance. Obesity has far-reaching health implications. It significantly increases the risk of type 2 diabetes, heart disease, stroke, hypertension, some cancers, and respiratory conditions like sleep apnea. It's also associated with mental health issues such as depression, anxiety, and eating disorders. Yet the most damaging aspect of obesity might not be medical. It may be social stigma. Individuals living with obesity are often judged, shamed, and discriminated against, including in healthcare settings, workplaces, and even within families. This stigma leads to poorer mental health outcomes, lower quality of care, and fewer people seeking help. In this series, we are going to go far beyond the headlines and explore obesity as a deeply human, biologically grounded, and socially embedded condition. We'll break down what causes obesity, not just from the perspective of calories in versus calories out, but by examining the hormonal, neurological, genetic, and microbial systems that regulate body weight. We'll discuss how urbanization, technology, culture, food marketing, and economic policy play crucial roles in shaping our habits and health. We'll look at how our gut bacteria, our childhood experiences, and even our sleep patterns can influence our long-term risk for obesity. We'll also explore what can be done. Treatment options have evolved dramatically in recent years. From lifestyle changes and behavioral therapy to FDA-approved medications to life-saving bariatric surgeries, there are more options now than ever before. But they are not equally accessible or well understood. We'll explain how these treatments work, who they're for, and how they can be combined with public health measures to create sustainable, society-wide change. And we'll also talk about prevention. What individuals, communities, and governments can do to stop obesity before it starts. Throughout this series, one principle will guide us. Compassion and evidence must go hand in hand. It is time to leave behind outdated myths and harmful stereotypes. Obesity is not a character flaw. It is not a failure of willpower. It is not a moral failing. It is a disease, one that is driven by biology and biology's interaction with a modern world that often works against our health. Understanding that is the first step to responding with the empathy, respect, and support that every person deserves. As you watch, I encourage you to think critically about the information presented and to reflect on how it applies not only to individuals, but to systems. How does our food environment influence what we eat? How does our neighborhood affect our ability to move? How does our culture frame body size, and with what consequences? Obesity is personal, but it is also political, social, and deeply cultural. It is a mirror reflecting many of the challenges we face in modern society, from inequality to industrialization to misinformation. By the end of this video series, you'll walk away with a comprehensive understanding of what obesity really is, what drives it, how it affects our health, and what can be done at every level, from the cell to the society, to turn the tide. Whether you're here to learn for yourself, support a loved one, improve your professional practice, or create change in your community, you've taken an important first step. Let's begin the journey of understanding obesity not as a label, but as a scientifically grounded story of the human body trying to adapt to a rapidly changing world. And like every complex story, it's one best approached with curiosity, humility, and a commitment to truth. To understand obesity at its core, we must begin with the systems within the human body that control energy balance. The body is not a passive vessel into which calories flow. It's an active, highly regulated organism with biological mechanisms that have evolved over millions of years to maintain survival in environments of scarcity. Ironically, in a modern world of overabundance, these very systems, designed to protect us, can now contribute to chronic disease. At the heart of obesity lies an imbalance between energy intake and energy expenditure. That much is true. But unlike a simple math equation, the components of this balance are shaped by an interplay of hormones, neural circuits, genetic instructions, and environmental signals. The body doesn't treat weight like a simple variable, it defends it, often vigorously, like a thermostat set to a particular number. This biological set point is maintained by complex feedback loops between the brain, fat tissue, muscles, gut, and pancreas. Let's start with hormonal regulation, one of the most powerful drivers of appetite and fat storage. The hormone leptin, discovered in the 1990s, is secreted by fat cells and acts on the hypothalamus, a region of the brain involved in hunger regulation. Leptin essentially communicates how much stored energy the body has. When fat stores are adequate, leptin levels rise, sending a satiety signal to the brain to reduce food intake and increase energy expenditure. However, in many individuals with obesity, the body becomes leptin resistant. Even with high levels of circulating leptin, the brain behaves as if the body is starving, triggering hunger, fatigue, and reduced calorie burning. This isn't laziness or lack of self-control, it's a biological drive shaped by disrupted signaling. Another key player is ghrelin, often called the hunger hormone. Secreted primarily by the stomach, ghrelin levels rise before meals and fall after eating. It stimulates the appetite and increases food intake. In people with obesity, ghrelin suppression after eating is often delayed or incomplete, prolonging hunger. This hormonal dysregulation can make sustained weight loss extremely difficult, as the body fights against it by increasing appetite and decreasing metabolic rate. Then there's insulin, a hormone produced by the pancreas that regulates blood sugar and also promotes fat storage. In many individuals with obesity, persistent overnutrition leads to insulin resistance, a state where the body's cells no longer respond effectively to insulin. This causes the pancreas to produce even more insulin, leading to hyperinsulinemia, which can exacerbate fat storage, particularly in the liver and abdomen. Over time, this insulin resistance contributes to the development of type 2 diabetes, fatty liver disease, and metabolic syndrome. The hypothalamus, located deep in the brain, is a command center for appetite and energy regulation. It integrates hormonal signals from the body and translates them into behavioral outputs, whether you feel hungry, full, energetic, or lethargic. It works closely with the mesolimbic reward system, which responds to the pleasurable aspects of food, especially those rich in sugar, fat, and salt. This reward circuitry, driven by the neurotransmitter dopamine, plays a crucial role in reinforcing eating behaviors. In modern environments where palatable, calorie-dense food is everywhere, this system can become hyper-responsive, leading to hedonic eating for pleasure rather than energy needs. Neuroimaging studies have shown that in individuals with obesity, the brain's reward centers often light up more strongly in response to food cues, while satiety centers show reduced activity. This suggests that for many, eating becomes neurologically driven rather than hunger-driven. It's not about willpower, it's about wiring. Genetics further complicate the picture. Numerous genes have been linked to obesity risk, many of which influence appetite regulation, fat storage, and metabolism. The FTO gene, fat mass and obesity-associated gene, is one of the most well-studied. People with certain variants of this gene are more likely to feel hungrier, prefer high-fat foods, and gain weight more easily. Another gene, MC4R, regulates the feeling of fullness after meals. Mutations in this gene are one of the most common genetic causes of severe early-onset obesity. These genetic factors don't determine destiny, but they influence vulnerability. Two people can eat the same meal and have very different hormonal and behavioral responses based purely on their genetic makeup.
Obesity is far more than a matter of body size or appearance. It is a condition that profoundly affects nearly every system in the human body. Its health consequences are wide-ranging, complex, and deeply intertwined. From chronic diseases to impaired quality of life, obesity increases the risk of morbidity and mortality in numerous ways. Understanding these consequences is essential not only for individuals living with obesity, but also for healthcare providers, policymakers, and educators seeking to promote public health. One of the most well-established associations is between obesity and cardiovascular disease, the leading cause of death globally. Excess body fat, particularly visceral fat which surrounds internal organs, contributes to several risk factors for heart disease, including hypertension, dyslipidemia, and atherosclerosis. Adipose tissue is not merely a passive storage depot, it is an active endocrine organ that releases inflammatory molecules called cytokines, as well as hormones like leptin and adiponectin. In obesity, this secretory profile becomes dysregulated, promoting chronic low-grade inflammation that damages blood vessels, impairs endothelial function, and accelerates plaque formation. Moreover, obesity is a major driver of type 2 diabetes mellitus, a condition marked by insulin resistance and high blood sugar. The link between the two is well established. Over 90% of people with type 2 diabetes are overweight or obese. In obesity, excess fat, especially around the liver and muscles, disrupts insulin signaling, making cells less responsive to the hormone. As a result, the pancreas compensates by producing more insulin, eventually exhausting its beta cells. If left untreated, diabetes can lead to complications such as kidney failure, blindness, nerve damage, and cardiovascular disease. Alarmingly, type 2 diabetes is now being diagnosed in adolescents and even children, a shift that parallels rising obesity rates. Obesity also plays a significant role in non-alcoholic fatty liver disease, NAFLD, a condition characterized by fat accumulation in the liver unrelated to alcohol use. In its early stages, NAFLD may be asymptomatic, but it can progress to non-alcoholic steatohepatitis, NASH, inflammation and scarring of the liver, which in turn may lead to cirrhosis and liver cancer. NAFLD is now the most common chronic liver disease worldwide, affecting up to 25% of adults, with obesity as the principal risk factor. The respiratory system is not spared. Obesity increases the risk of obstructive sleep apnea, OSA, a disorder in which the upper airway repeatedly collapses during sleep, causing breathing to stop and start. This results in fragmented sleep, daytime fatigue, and reduced oxygenation. In the long term, untreated OSA contributes to high blood pressure, heart failure, stroke, and metabolic dysfunction. Fat deposits around the neck and chest can physically narrow airways and restrict lung expansion, while systemic inflammation may also play a role. In the realm of musculoskeletal health, obesity places additional strain on joints, particularly the knees, hips, and spine. Over time, this mechanical load accelerates wear and tear, leading to osteoarthritis, a painful condition marked by cartilage breakdown and reduced joint mobility. Obesity also worsens outcomes in people who already have arthritis and makes physical activity more difficult, creating a vicious cycle of pain, inactivity, and further weight gain. Reproductive health is also impacted. In women, obesity is associated with polycystic ovary syndrome, PCOS, a hormonal disorder that affects ovulation, menstrual regularity, and fertility. Excess fat alters the balance of sex hormones, increasing estrogen and androgens, like testosterone, which disrupts ovarian function. Obese women are also at higher risk of complications during pregnancy, including gestational diabetes, preeclampsia, and cesarean delivery. For the fetus, maternal obesity increases the risk of premature birth, congenital anomalies, and later life obesity and metabolic disease. In men, obesity can reduce testosterone levels, lower sperm quality, and contribute to erectile dysfunction. Beyond physical health, obesity has significant implications for mental health and emotional well-being. Numerous studies have found strong associations between obesity and depression, anxiety, low self-esteem, and body dissatisfaction. These relationships are bidirectional. While excess weight can contribute to psychological distress, mental health conditions can also lead to behaviors that promote weight gain, such as emotional eating, physical inactivity, and disrupted sleep. Social stigma compounds these challenges. Individuals with obesity are often subjected to weight bias, discrimination, and bullying, which can occur in schools, workplaces, healthcare settings, and even within families. This stigma is not only morally unjust, it is medically harmful. It increases stress, discourages healthcare utilization, and worsens outcomes. Obesity also elevates the risk for several types of cancer. The strongest evidence exists for endometrial, breast, postmenopausal, colorectal, kidney, pancreatic, esophageal, and liver cancers. The mechanisms are multifactorial and include chronic inflammation, hormonal imbalances, particularly estrogen and insulin, altered immune function, and changes in the tumor microenvironment. For example, fat tissue in postmenopausal women is the primary source of estrogen, which can stimulate the growth of estrogen-sensitive tumors. Obesity also interferes with cancer screening, diagnosis, and treatment efficacy, contributing to poorer outcomes. Cognitive health may also be affected. Emerging research suggests that obesity is linked to cognitive decline, dementia, and Alzheimer's disease. The mechanisms are still being elucidated, but chronic inflammation, insulin resistance, and vascular dysfunction are thought to play key roles. Obesity during midlife appears to be particularly harmful, as it may set the stage for neurodegeneration decades later. Life expectancy is another sobering metric. While not every individual with obesity will experience serious complications, population studies show a consistent trend. Obesity shortens lifespan. A meta-analysis of over 10 million people found that individuals with a BMI of 30-35 had a 1.2-fold higher risk of premature death, while those with a BMI over 40 had nearly double the risk. The causes of death are typically cardiovascular disease, cancer, and diabetes-related complications. Yet it is important to emphasize that health is not determined solely by weight. Many people with obesity have normal blood pressure, glucose levels, and cholesterol, sometimes referred to as metabolically healthy obesity, MHO. Conversely, some individuals with a normal BMI may have visceral fat, inflammation, or poor metabolic health, a condition called TOFI, thin outside, fat inside. Therefore, health assessments should consider more than BMI alone. Waist circumference, body composition, fitness level, diet quality, sleep, and mental well-being all provide valuable context. This complexity underscores the need for holistic care. Treating obesity's health consequences requires more than weight loss. It demands managing blood pressure, improving glucose control, reducing inflammation, supporting mental health, and fostering healthy behaviors. Medications, lifestyle counseling, psychological support, and when appropriate, bariatric surgery all play roles. Preventing complications before they arise is even more powerful. Early intervention in childhood or adolescence can dramatically alter the trajectory of health across the lifespan. Crucially, we must recognize that the burden of obesity-related disease is not evenly distributed. People in marginalized communities, whether due to race, income, geography, or disability, often face higher risks and worse outcomes. Structural inequalities, including limited access to care, healthy food, safe neighborhoods, and health education, exacerbate this disparity. Tackling the health consequences of obesity must therefore go hand in hand with equity-focused public health policies that address the root social and economic causes. Ultimately, the health consequences of obesity are not just medical, they are social, emotional, and economic. They affect not only individuals but families, communities, and healthcare systems. The challenge is immense, but so is the opportunity. With science, compassion, and collective action, we can reduce this burden and help people of all sizes live longer, healthier, more fulfilling lives. When we talk about obesity, the conversation often centers on diet, exercise, and disease. But one of the most powerful and insidious forces shaping the lives of people with obesity isn't biological, it's societal. Obesity stigma, or weight bias, is a pervasive form of discrimination that affects everything from mental health and employment to education and medical care. Its consequences are real, measurable, and deeply damaging. To understand obesity fully, we must also understand the psychology of how we treat people who live with it. Weight stigma refers to the social devaluation and denigration of individuals because of their body size. It manifests as negative stereotypes, such as the belief that people with obesity are lazy, unmotivated, lacking in self-control, or unintelligent. These biases are not limited to a fringe minority. They are deeply embedded in media, education, public health messaging, and even within healthcare systems. Studies show that weight-based discrimination is now as common as racial or gender discrimination, especially among women. Media plays a significant role in shaping public attitudes. In film, television, and advertising, people with larger bodies are frequently portrayed as comedic relief, villains, or objects of pity. They are rarely shown as complex, successful, or desirable. News coverage often relies on dehumanizing images. Anonymous photos of bellies, people eating junk food, or struggling to walk. These depictions reinforce the idea that obesity is a moral failing, rather than a multifaceted medical condition. The consequences of weight stigma are profound and paradoxical. Instead of motivating positive change, stigma often leads to worse outcomes. People who experience weight discrimination are more likely to engage in unhealthy behaviors, such as binge eating, avoiding physical activity in public, or delaying medical care. They report higher levels of depression, anxiety, low self-esteem, and suicidal ideation. In children and adolescents, weight-related bullying is among the most common and damaging forms of harassment, linked to academic difficulties, social withdrawal, and long-term mental health issues. Even healthcare is not immune to weight bias. Studies have shown that medical professionals, doctors, nurses, dietitians, and therapists often harbor implicit and explicit negative attitudes toward patients with obesity. These biases can lead to shorter appointment times, fewer diagnostic tests, and reduced empathy. Some patients report feeling dismissed, blamed, or humiliated during medical visits, which causes many to avoid or delay care altogether. The irony is that while obesity increases the risk for numerous health conditions, stigma makes it harder for patients to receive proper treatment. This creates a dangerous feedback loop. Stigma leads to avoidance of health care, which leads to undiagnosed or poorly managed conditions, which leads to worse health, which further reinforces stigma. Addressing this cycle requires not just individual awareness, but systemic change. The roots of weight stigma are complex. Part of it stems from cultural values that equate thinness with health, beauty, and success. In Western societies, in particular, the ideal body type has narrowed over time to an increasingly lean and often unattainable standard, especially for women. At the same time, obesity has become medicalized, seen through a clinical lens as a problem to be solved, which, while useful in some respects, can also contribute to pathologizing individuals rather than supporting them. Economic and political factors also play a role. Public health campaigns sometimes unintentionally perpetuate stigma by using fear-based messaging or shaming language. While well-meaning, these efforts can alienate the very people they aim to help. Instead of promoting empowerment, they reinforce the narrative that people with obesity are to blame for their condition and deserve to be corrected or fixed. There is also a historical dimension. Fat phobia has roots in colonialism, racism, and classism. In the 19th and early 20th centuries, ideals of thinness were promoted in part to differentiate the white Western elite from the colonized and working-class populations whose bodies were often portrayed as excessive, undisciplined, or inferior. These narratives continue to influence how bodies are valued and judged today. Psychologically, the internalization of weight stigma, believing that one is personally to blame or deserves negative treatment, can be even more harmful than external stigma. This internalized bias has been linked to disordered eating, chronic stress, cortisol dysregulation, and even metabolic changes that promote weight gain. In other words, the shame people feel about their bodies can directly impact their physiology, further complicating efforts to improve health. So how do we combat stigma? First, we must shift the narrative from blame to understanding. Obesity is a complex condition influenced by genetics, biology, environment, and socioeconomic factors, not just personal choices. Educating the public about this complexity can help dismantle simplistic and harmful stereotypes. Language matters. Terms like obese person can be dehumanizing. Many advocates recommend person-first language such as person with obesity, which emphasizes the individual, not the condition. Second, we need to promote weight-inclusive healthcare, an approach that focuses on health behaviors rather than weight as the primary indicator of well-being. This includes principles like health at every size, HEAS, which encourages intuitive eating, joyful movement, and body acceptance. While HEAS is sometimes misinterpreted as anti-health or anti-weight loss, its core message is that people of all sizes deserve respectful, evidence-based care, and that well-being is not dependent on reaching a specific weight. Third, clinicians and educators must examine their own biases. Implicit bias training, empathy-building exercises, and diverse representation in medical education can help reduce prejudiced attitudes. Research shows that even brief interventions, such as watching a short video about the lived experiences of people with obesity, can reduce bias among health professionals. Fourth, the media must play a role in promoting body diversity and positive representation. This means including people of all sizes in fashion, entertainment, and advertising, not just as token figures, but as fully realized characters and role models. Social media movements like #bodypositivity and #fatacceptance have made significant strides in this area, though they also face backlash and misrepresentation. At the individual level, cultivating self-compassion and body neutrality can be powerful tools. Rather than forcing oneself to love their body in a culture that often doesn't, body neutrality encourages focusing on what the body can do rather than how it looks. Psychological therapies such as cognitive behavioral therapy, CBT, acceptance and commitment therapy, ACT, and mindfulness-based approaches can also help individuals cope with internalized stigma and improve their relationship with food, movement, and self-image. Finally, stigma must be addressed through policy. Anti-discrimination laws should include weight as a protected category, as they do for race, gender, and disability. Schools should implement anti-bullying programs that specifically address weight-based harassment. Employers should be held accountable for weight bias in hiring and promotion, and public health campaigns must be designed with sensitivity, inclusivity, and an emphasis on empowerment rather than shame. In sum, the psychological and social dimensions of obesity are not peripheral, they are central. Until we create a culture that supports people in larger bodies with dignity, respect, and evidence-based care, we will continue to see the same harmful patterns repeat. Stigma is not only unjust, it is scientifically counterproductive. It undermines health, prevents progress, and perpetuates suffering. As science advances our understanding of obesity, society must also evolve in how it responds. Empathy, education, and equity are as essential as any medical breakthrough. Only by addressing both the biological and psychological realities of obesity can we hope to create a world where all people are supported in achieving health, not defined by their weight, but by their humanity. If you found this video helpful, don't forget to give it a thumbs up, share it with your friends and family, and most importantly, subscribe to the channel for more simple health tips that make a big difference. And while you're at it, tap the notification bell so you never miss out on our latest content. Thanks for watching, and we'll see you in the next video. Stay healthy and keep smiling.